Okay. Hi everyone, I'm Peter Spielsberg. I'm the director of the strategy unit. This piece of work is a very substantial piece of work, and it's being published in the next couple of days, and there is actually a webinar tomorrow which I'll tell you about at the end. So I'm not even going to attempt to cover it off in detail, but I just want to give you a few headlines, partly just hopefully to entice you to want to follow through to the report itself, or maybe to join the webinar. So this is one of the first projects that was prioritised by the network. So the members of the network, each ICS participates in a process each year where they choose the priority projects for these regional reports. There's a long list and a voting process. So this is owned by the members. And one of the projects they chose was to look at socioeconomic inequity in plan care. And the objectives of this project are described there. So we wanted to describe the position. We wanted to try and understand a bit more about at which point on patient pathways inequalities in access emerge, and we wanted to try and understand about the interrelationship between this and plan care, urgent care. Sorry, if you move to the next slide, Simon. And then lo and behold, the planning guidance has just come out and actually introduces a requirement for systems to be looking at their equity position in relation to plan care in the context of elective recovery, and even stipulate some conditions for access to the elective recovery fund in relation to this. So the analysis is very timely. So our systems were ahead of the game in spotting priorities. Anyway, if you go to the next slide, I'll just whiz through these. So this just shows the amount of activity and how it's grown over the last period for elective spells. So we've had a considerable increase in elective activity since the early 2000s to date, as you can see there. If you go to the next slide, Simon. And at the beginning of that period, the crude rates of elective activity favoured those living in the most deprived areas. So across the bottom of these charts, you've got the index of multiple deprivation running from 1 to 10, 1 being the most deprived, 10 being the least. And these are crude rates, they're not needs weighted, which would probably make the position more striking. But at the end of the period, the situation had changed. And certainly for elective spells, we're seeing now the crude rates of activity are highest amongst the least deprived populations. So if you move to the next slide, and if you look at in this period where there has been substantial growth in activity and improvements in performance, or at least until recently, but during that period we succeeded in achieving growth rates in activity that were highest for those in the least deprived communities. So we have succeeded in this period in exacerbating the inverse care law first set out by Tudor Hart. Go to the next slide. And if you look at the pattern across all the major causes of morbidity, you find that in most instances, the activity skewed towards people living in the least deprived areas. And that chart shows that running down from cancer down through various conditions. And if you go to the next, and we see the position replicated pretty much in all our ICSs. Every one of our ICSs gets a bespoke report out of this, very detailed report with all the code and all the data assignments there. So this is just a sort of headline summary. So there isn't really anywhere that isn't showing this type of gradient, but the pattern does vary, and we've got some places where the gradient is much greater than others, as you can see there. And obviously people outside the Midlands will be interested to know what their position is, I suspect. And hopefully can use the code that we're making available to replicate this analysis, or if not, come to us. Okay, go to the next. I think this is quite a striking finding. I'm not sure people have been aware of this before, but we started paying for large amounts of activity in the independent sector in the early 2000s. What this chart shows is that the vast majority of take-up of that NHS funded independent sector offer has been in the most advantaged groups in society. dramatically so. If you go to the next slide, and even possibly worse, if you look at the length of time people have waited for treatment, the beginning of this period it was slightly skewed in the favour of the most disadvantaged, but we've now managed to achieve a position where the people in the most advantaged populations are not only getting more access, they're getting it faster. Next. I'll just summarise this. There's a lot of detail on this in the report, but if you, in the next section of the work, if you go to the next slide, Simon, we move much more into a needs-based denominator, and we looked at 4 large-scale pathways, as you can see there, and we broke those pathways down into stages, from presentation through diagnosis, through referral, through to treatment, in order to try and see at which point the equity occurred. And we had a set of expectations of this, which I have to say were thwarted by what we found, because what we found is in the next slide. Slightly difficult to read, but down the right hand side you've got the stages in the pathway, and across the top you've got these 4 pathways: COPD, heart failure, hip and cataract. And what we found in all these instances is that the inequity cut in at the point of secondary care treatment, and that in fact prior to that most of the stages of the pathway were slightly skewed towards disadvantaged populations. So something is happening as part of the process by which people proceed to treatment where inequity is occurring. And one of the hypotheses in our report is that there's some kind of toxic mix of the way we've conducted choice policy, lifestyle, kind of criteria for access to treatment, a bunch of other things, a bunch of policies where maybe we haven't thought enough about their differential access on people from different communities and different backgrounds. If you go to the next slide. Now, I'm not going to tell you the answer to this one because I want you to go and read the report, but in this analysis we have shown at a macro level, of course, a statistically significant and robust relationship between levels of planned care and levels of unplanned care, and the analysis shows the extent to which reducing the inequity in planned care would have a positive impact on rates of unplanned care, and scales that for systems and starts to set out an equation by which people can think about the system level benefit of systematically setting about reducing inequity in access to planned care. So if you go to the next slide, there's the webinar launching this analysis in detail with Stephen Wyatt, who's the chief analyst of the Decision Support Centre, is tomorrow. So short notice, but you're welcome to join it between 12 and 12:50. The report itself has been published in the next few days and will be widely publicised across the NHS. And we hope that it can stimulate local areas into thinking about how they can tackle these problems. Thank you.